Hello everyone. For those of you who were not at ESRA this year in 2022, I thought I'd record my presentation from the meeting where we were talking about indications for trunk wall blocks, and I was talking about blocks for breast surgery. So I have a few disclosures, none of which will impact on my ability to deliver this talk, but I did want to highlight the use of the Complete Anatomy app by 3D4 Medical. Before I start this presentation, I really do have to say some thanks. Some thanks to Rafa Blanco and Teresa Paris, who were instrumental in me getting involved in regional anesthesia for breast surgery, both inventors of the PEX blocks and serratus anterior plane blocks, and to John McDonnell and Manoj Karmarkar, who were instrumental to me when it came to learning about paravertebral block that will feature heavily within this presentation. So in the past, when I've given my previous breast talks, I've given them with some very powerful leaders in regional anesthesia. Back in ESRA2016 with Teresa Paris, ESRA World with Meg Rosenblatt, and then recently at RUK ESRA2022 with Sandy Kopp. But this time, it's just me giving my opinion, so I feel a little bit exposed about it. What are we going to be covering? So I'm going to be covering why we should block the breast, cover the spectrum of surgery. Then I'll cover 5 general block questions I think one should ask whenever one's considering performing regional anesthesia. We'll have a brief look through the anatomy, we'll look at the block choices, and then talk about some of the optimal techniques. But I do want to start by giving you one of 2 spoiler alerts. The first alert is I think that the paravertebral block is the king of blocks, and it won't surprise you therefore to see that the paravertebral block features heavily within my talk. The second spoiler alert, which is something that may come as some surprise, is that actually the truth is nobody has to have a block. And there are some situations where it may be sensible to give the surgeon a local anaesthetic instead of you performing a block yourself. So just because you can doesn't mean that you should. So why should we block the breast? Well, there are a whole host of very obvious reasons. Number one, the reduction of acute pain and the potential impact to reduce chronic post-surgical pain or chronic pain. Opioid reduction in nausea and vomiting. There's certainly a lot of evidence now looking at the potential benefits of regional anesthesia in improving quality of recovery, improving ambulation, and in fact, in some circumstances, using regional anesthesia as an alternative to general anesthetic. So there are very many reasons why one should consider blocking the breast. But breast surgery is not all the same. There's clearly a spectrum of breast surgery. If you have a look on the left-hand side of the screen, you've got symptomatic non-cancerous breast surgery, such as duct surgery or excision of fibroadenoma. And on the far right-hand side, you've got a lot more of the involved procedures, starting off with just a wide local excision, but then progressing into a slightly more complicated oncoplastic procedures where they mobilize breast tissue to fill a defect, and therefore this is a little bit more disruptive of tissues and may cause a lot more pain. And then of course you have all of the clever autologous free flap or pedicled flap reconstructions. All of these cancers can of course be performed in addition to axillary surgery, but for the purpose of this talk I want to focus really just upon the oncological and oncoplastic surgery plus or minus axillary surgery. And this gives us kind of a refined group of procedures to look at. So what are those general block questions, those 5 block questions, or PowerPoints as I like to call them? Well, let's start off. The first thing you've got to ask yourself is what block would give you the best analgesia or anesthesia? All things considered, if you could do the best block to get the best results, what would that be? You then got to ask yourself, does the risk-benefit ratio favor you using this technique for this particular surgery? There may be some situations where you're doing a small lumpectomy or a wide local excision where clearly a paravertebral block would be best, but can you justify the risk of the paravertebral block in that particular circumstance? So then you need to consider question number 3, which relates to patient factors. Does their anatomy favor a technique, or in fact advise you against doing a technique? Are there other risk factors to think about, such as their anticoagulation status, infection status, whether they have pre-existing pain, or whether they have significant respiratory dysfunction, which may mean that using opioids instead of regional anesthesia would be problematic. Question number 4 are relating to anaesthetist or surgeon factors. Do you as the anaesthetist have the skill levels required to deliver that ideal block? How comfortable is the surgeon to have you put local anesthetic perhaps in the field where they're going to be operating? And lastly, what happens if you don't do anything? Or if you don't do your primary technique, are there alternative strategies that may be relevant? So those 5 questions I think are relevant when you're thinking about any technique, and I'll use that as a framework when discussing the techniques. So let's start off by looking at the anatomy. So we all know the standard approach here when we look at our dermatomes, and you'll see a variation in the public literature, in the published literature in terms of where those dermatomes cut off, but you get the general idea from here. Then let's have a look at those nerve territories. Of course, we've got the supraclavicular nerves taking out the superior aspect of the chest wall, not necessarily relevant for surgical incisions because many surgical incisions are not that high, but it's important to know them. Then, of course, got the anterior cutaneous branches and the lateral cutaneous branches of said intercostal nerves. You've also got nerves relevant for the axilla, so the intercostal brachial and the medial brachial cutaneous nerves. The long thoracic nerve coming down to serratus anterior, and of course you've got the medial and lateral pectoral nerves, of which there is some controversy as to whether or not you think they're relevant for supplying analgesia required for breast surgery. Now, with those blocks, or with those nerve territories in mind, what are the block choices that we can choose from? Well, in order to have a look at those block choices, let's take a look through into thoracic arc. So we'll have a look here. So of course we've got paravertebral, as I mentioned before, and I'm going to be using the correct terminology now as per the nomenclature paper. And if you scan the QR code in the top right hand corner of the screen, that will take you to a paper where we've looked at the Delphi consensus to which block names we should be using. So you've got the paravertebral block, then you've got the paraspinal blocks, and that encompasses, to name a few, the erector spinal plane, the retrolaminar block, and the intertransverse process block, formerly the MTP block. You then got the anterolateral chest wall blocks. Now, these are the pectus serratus plane and interpectoral plane, formerly PEX blocks, and the serratus anterior plane, and then of course the anteromedial chest wall blocks, of which there are deep and superficial variants of the parasternal intercostal plane. So having got all of those names, how do we relate those to where we're going to be performing them? So let's have a look at the schematic here. Of course, you've got the paravertebral block in the paravertebral space. You've got a group of paraspinal plane blocks here, the ESP, retrolaminar, and intertransverse process. You've got the interpectoral and pectus serratus plane, and of course, the serratus anterior plane. And then last but not least, covering the anteromedial chest, we've got the deep and superficial parasternal intercostal plane blocks. So this gives you an idea of where, related to the chest wall, you can numb those particular regions. So now we've got an idea of all the blocks. What should we use for different procedures? So we've got some guidance here. We've got the prospect guideline, of which they've produced so many useful guidance for different surgeries, and that QR code will take you to the paper. What did they say? Well, the prospect guideline said that everybody should get pre-op gabapentin. I'm not entirely sure that that's necessarily something that everyone will be practicing, but they did say that we should be using multimodal analgesia, using intravenous dexamethasone as an adjunct, part of that package, and only to use opioids as a rescue. For minor breast surgery, they recommended local anesthetic infiltration, and for major breast surgery, they suggested we should use a paravertebral block, or if paravertebral was contraindicated and there was no axillary surgery, a PEX2, they called it, plus or minus local infiltration as required. The question is, do you agree with that? And I'm going to tell you why that may not necessarily be the full picture, because when you're considering performing any of these techniques, you've got to ask yourself, are you doing this technique for analgesia or for anesthesia? Which aspect of the breast is being operated on? And is the axilla involved? Because if it is involved, it may require you to refine your techniques. You've also got to think about what the likely pain trajectory is. If it's short surgery that's going to last 20 minutes and it's unlikely to cause significant pain, maybe the time, effort, and risk involved with siting a block may not be justified. Whereas if it's longer surgery that will last for a few days with regards to pain, maybe one needs to think about doing something different. And also you've got to think every time you do a block, will my surgical colleagues be happy with the technique that I'm using? This schematic diagram I've used in lectures before gives you a rough idea, it sort of maps out where these particular nerve blocks might take out certain territories and where they may be useful. You'll see the interpectoral technique, for example, is just useful for lateral and medial pectoral nerves, whereas the pectus serratus and serratus anterior blocks take out other aspects of the breast. So this gives you an overview, but I'm not alone in thinking that maybe the prospect guidance isn't 100% ideal, because there's this paper over here. Again, if you scan this QR code, it will take you to a nice bit of correspondence in anesthesia. And these Italian authors said, well, they questioned, why are we only using PEX blocks if paravertebral is a contraindicator and there's no axillary dissection? They questioned that. And they also said, why do PEX blocks and paravertebral not cover the axilla? Because their experience, and certainly my experience, is that you can utilize those techniques to get axillary analgesia. And they also questioned the utility of comparing PEX, paravertebral, and serratus, as they all target different nerve structures in different regions. So now let's look at those techniques through a slightly different lens. So let's revisit our anatomy. Here we've got our dermatomes, but let's look at what these different blocks might do. So we know here, if we expose some of the tissue here, that the supraclavicular nerves are relevant for covering the superior aspect of the chest. The anteromedial chest wall blocks, so the parasternal intercostal blocks, cover the medial aspect of the breast, medial to that middle half of the nipple. The interpectoral and pectoris serratus, again, cover the lateral aspect of the breast. And the serratus anterior, just by itself, covers, again, that lateral aspect of the breast. If you overlay what's covered by the paravertebral block now you can see how you actually have got a decent plan or schematic for deciding what to do when. And again, you can see the interpectoral and pectoral serratus and the paravertebral do cover the axilla to a certain extent. So let's now revisit those PowerPoints. Number one, what block gives you, or what in an ideal world will give you the best analgesia or anesthesia? Looking at the risk-benefit ratio, the patient factors, the anaesthetist and surgeon factors, and what are your alternative strategies, or what happens if you do nothing? So now let's look at a wide local excision lumpectomy or minor surgery. Probably in terms of analgesia, the paravertebral block is probably best, but one has to question the risk-benefit ratio when doing a paravertebral block for a short procedure in a patient that may not necessarily require that level of analgesia. You've got to consider your patient factors. If you have a patient who has significant respiratory embarrassment and in whom giving opioids afterwards may be problematic, even though it's a small surgery, a paravertebral block with dense analgesia may be better. You also got to think about your staff skill needs. If you've got an anaesthetist covering the list and you don't have the skills to do paravertebral, it may be that you could actually look at some of the alternatives. So what are the alternatives? Well, you could do local anesthetic infiltration, and that may be sufficient, but you could also consider doing location-dependent blocks. So what do I mean by that? If you've got medial surgery in the medial part of the breast, you could add in parasternal intercostal plane blocks instead of doing a paravertebral. If it's lateral, you could consider doing pectoris serratus or interpectoral pectoris serratus combinations. One thing you could consider doing is doing an ESP block or an ESP plus an intertransverse process block. So my practice now when I'm training to do paravertebrals is to get people to do an ESP block. And at one point where the maximal point of surgical pain is, I ask the trainees to advance the needle into that intertransverse process plane and to supercharge the ESP. That's certainly not as risky as doing a paravertebral block, maybe doesn't require as much skill, so that's something to consider. What about mastectomy plus or minus an implant-based reconstruction? I think there's no doubt, in my opinion, that paravertebral block is probably the best in terms of analgesia, and it's likely to be beneficial. So actually, for the risk-benefit ratio, paravertebral is likely to be beneficial, assuming there are no contraindications and the patient gives consent to do that, and also assuming you can do that. If, however, you don't have the skills to do that block, or you don't think risk-benefit ratio is in favor of doing a paravertebral block, you could consider doing a combination of anteromedial chest wall blocks, so the parasternal intercostal plane, plus some anterolateral blocks. Again, you could consider doing an ESP or a supercharged ESP block in this point as well. But if all else fails, you do have the ability to ask the surgeons to do local anesthesia infiltration. And often on lists where I'm not covering them, my surgical colleagues will do surgically sited interpectoral plane and pectoris serratus plane blocks. Now, I did want to look at the axillary node dissection as a separate entity here, and this involves taking out the full axillary contents. And in my practice, in my experience, Interpectoral plane and pectoral serratus plane blocks are really useful here at giving you decent axillary analgesia. And if ever there'd been a situation where I've left that out of my block recipe, the patients have suffered significant discomfort afterwards. I think these techniques are relatively low risk compared to paravertebrals. And again, you need to consider patient factors and the fact that your surgeon may not like operating on a wet or edematous axilla. But I have managed to work with surgeons over a few years and they are happy operating in those conditions. What are the alternatives, however, if they say we don't want you to do a PEX block, formerly PEX block, or interpectoral pectoral serratus plane? You could do T1, T2, or T2, T3 paravertebral block, slightly higher to site, those slightly higher techniques, but that is also there. Or you could do a deep serratus anterior plane block. And in some cases, that is an alternative that surgeons are happy with. Failing that, you can do local infiltration, but it's very difficult to do infiltration as you go when you're doing an axillary node dissection. And often once the axilla has been removed, it's difficult to site local anesthetic in all the places where the patient may be experiencing discomfort. Another question I get asked often is, does the interpectoral and pectoral serratus plane block affect the surgeon's ability to identify some vital neural structures using the diathermy? Many people have said that their surgeons are anxious about that, but I'm going to show you that actually here's a patient in whom a PEX block or interpectoral plane block have been sited, and you still get a muscle twitch by buzzing on the nerves here. And here is now in a wet axilla where a PEX block has been observed, you can see direct stimulation of those nerves still cause muscle contraction. So actually, generally, PEX blocks do not impair the surgeon's ability to identify nerves. What about that niche group of patients having flap reconstruction? So if you've got a pedicled flap, such as the latissimus dorsi flap here, I think paravertebral is likely to be best, and I often perform a 2-level block. But beware if you're going to use something like a serratus anterior plane block that you don't damage that thoracodorsal arch, you don't damage the pedicle that they're going to be operating on. But you could consider doing some alternatives, an ESP or intertransverse process block, or even a rhomboid intercostal block. How about mastectomies where they do a free flap reconstruction, such as what's depicted here, the deep inferior epigastric perforator artery flap? Well, in this case, the abdominal pain is likely to be far more significant than the pain from the breast, and that's certainly my experience. And often the patients don't complain of pain in the breast after surgery. So in my personal practice, I don't do a regional anesthetic technique for the breast, and I tend to cite quadratus lumborum blocks. I do posterior quadratus lumborum blocks, or if the surgeons prefer, they can do a surgically sited transversus abdominis plane block or rectus sheath blocks at the end of the flap harvest. I also use this in combination with multimodal analgesia, and often that is sufficient for these patients. There's another niche area now, of course, and that's awake breast surgery. And the QR link here will take you to the initial paper we published. So I think a multi-level paravertebral is almost certainly best. And you could consider, if local anesthetic volume will allow, adding in interpectoral and pectoral serratus plane blocks. Or if you're not comfortable doing that technique, you can, of course, do an anteromedial chest wall block plus anterolateral. And we have used this with good effect, depending upon the type of surgery that's being used. But you could also consider doing awake surgery under intertransverse process blocks, and certainly there have been a number of case reports where this has been done. A brief look now at some of the evidence. There is now evidence out there that shows that using paravertebrals is associated with a higher quality of recovery compared to not using paravertebral. In this study, they use placebo here. So you can see paravertebrals make a difference. There's also a publication in April 2022 for the Society for Ambulatory Anesthesia, and they came up with some guidelines after looking at the evidence and said for lumpectomy or breast conserving surgery, use interpectoral pectoral serratus plane blocks in the absence of systemic analgesia. Now, I can't think of very many situations where you're not going to be using systemic analgesia. And they also stated they could not recommend interpectoral pectoral serratus over surgical local infiltration or vice versa. So for small surgery, you could do either or, but the evidence doesn't push you one way or another. For major surgery and mastectomy, they said certainly use interpectoral pectoral serratus plane blocks if you are unable to site paravertebral. And I think that's fairly reasonable. There's also a really nice systematic review and network meta-analysis published in January 2022, where they looked at a whole host of regional anesthesia techniques. That QR code there will take you to the paper. And what they concluded was that any regional anesthetic technique was more effective than no intervention. So that's a really useful point. If you do something, it's better than nothing. They also commented that paravertebral blocks were consistently ranked higher than other regional anesthetic techniques, but they had more complications. They certainly had an instance of pneumothoraces that was evident. The other thing that was interesting was they noticed that the serratus anterior plane block had a high probability of reducing pain at 24 hours and a relatively low risk of complications. So clearly paravertebral seems to be great, but it has risks, and there are alternatives such as the serratus anterior plane block. So what does this all mean? What should the takeaway points be? Well, I think not all breast surgery is equally painful, and that's relatively evident from what we've discussed thus far. And certainly not all patients have the same pain outcome. Somebody having minor surgery may have significant pain, whereas somebody having major surgery actually may not have that great a pain trajectory. It's really important that we should individualize our patient care, discuss it with the patients, and make sure we use multimodal analgesia as part and parcel of the package. So certainly in the case of minor surgery, it's possible you can manage without regional anesthesia and either supplement that with surgical infiltration or do some of the more minor blocks. Major surgery certainly benefits from using regional anesthesia. And if you have the skills and the ability, place a paravertebral block. If the risk-benefit ratio is not in favor of paravertebral blocks, there is certainly a role and evidence that fascial plane blocks are the way to go, and they're better than doing nothing. But don't give up on the erector spinalis plane block. Why do I say that? If you take a group of anesthetists and say, look, how many of you guys are happy to cite a paravertebral block, you get a small proportion. Take the same group and say, well, how many of you are prepared to go a little bit closer? You get a larger number of people. Actually, if you say how many of you are prepared to do an erector spinalis plane block, you get a much larger number therefore. So if you've got more people that are prepared to do an ESP block, whether or not you believe the evidence, you can then use the erector spinalis plane block to teach the paravertebral by skill progression. Sequentially learn to take the needle a little bit closer to the paravertebral block, and when you've got the skills, deposit it in the paravertebral plane. The last thing I want to remind you is I do think the paravertebral is the king of blocks, and you can utilize that to great effect in breast regional anesthesia. If you want, you can check the rest of my block videos out on this channel, and there's a playlist I've created here with a whole host of techniques that will hopefully be useful for you. I do also want to highlight this paper, which gives you sort of a review of a lot of the fascial plane blocks I've been referring to as well. Thank you very much for taking the time to listen. I do hope you found that useful, and please like and subscribe if you like what you see. Many thanks.